lecture, we'll be discussing infections. We'll also be discussing their implications as it pertains to pregnancy. I'll be discussing infections and breaking it down to 3 subcategories. These are vaginitis, sexually transmitted infections, and perinatal infections. In case you're interested, the picture is a picture of the herpes virus. Vaginitis is a condition that sends many women to their gynecologist. This is the most frequent chief complaint of women who visit their OBGYN. Symptoms of vaginitis include vaginal discharge, foul odor, irritation of the perineal area, itching, and dyspareunia. What is that? That is painful intercourse. Specifically, vaginitis can be bacterial vaginosis or candidiasis, which is a yeast infection. The first type of vaginitis we'll discuss is bacterial vaginosis. Here, there is a vaginal infection related to changes within the normal flora of the vagina. There's overgrowth specifically of anaerobic bacteria, which leads to an increase in the vaginal pH. So is it becoming more basic or more acidotic? It's becoming more basic. As you'll recall, a decrease in pH means acidosis. So an increase in pH levels equals more basic environment. Bacterial vaginosis is not necessarily a sexually transmitted infection, although there's some controversy because it is more frequent in women who are sexually active. Signs and symptoms would appear vaginal discharge, foul odor of vaginal discharge, and if we were to get a sample and put it on a wet mount on a slide and look at it, there would be the presence of what we call clue cells. Vaginosis is frequently treated with flagyl or clindamycin therapy. As it pertains to pregnancy, bacterial vaginosis may be related to vitamin D deficiency in pregnancy, increased fat intake during pregnancy, folate, vitamin A, and calcium. So this is a time when there may be a setup for bacterial vaginosis due to these factors. Bacterial vaginosis, if present during pregnancy, is also associated with preterm labor and birth, so we certainly want to screen for this and treat it with the antibiotics that were mentioned. As I said, it's often treated with flagyl and clindamycin. However, there is some concern regarding the use of flagyl during pregnancy. The CDC now states that it is safe to use flagyl during pregnancy. However, you may see that some providers shy away from this. There used to be a thought that flagyl was a potential teratogen, or it could cause anomalies within the developing fetus. So to be on the safe side, some providers just stick with clindamycin for bacterial vaginosis in the pregnant patient. Vulvovaginal candidiasis is another form of vaginitis. It's commonly known as a yeast infection. This is a fungal infection. Signs and symptoms include itching, a red rash, or cheese-like discharge. As you can see in the picture, this is a picture of a cervix. So during an exam, a speculum was used to visualize the cervix, and you can kind of see that cheesy coating that is around the cervix. This may also be exiting the vaginal area, so she may see these secretions and report them. This is typically treated with diflucan, which is a PO medication, or topical antifungals such as nystatin. During pregnancy, if she has a yeast infection at the time of delivery, the newborn may have thrush or yeast infection. Often this is seen in the inside of the mouth or can be on the skin. During pregnancy, diflucan, the PO antifungal, is not used. During pregnancy, we only use topical agents like nystatin. Moving on to sexually transmitted infections, we'll be considering Trichomonas, Chlamydia, Gonorrhea, Herpes, Syphilis, HPV, and HIV/AIDS. As we begin the discussion of sexually transmitted infections, we'll first consider prevention. We want to counsel people who are at risk. What is the only way of preventing a sexually transmitted infection? It's abstinence, not engaging in sexual intercourse and sexual acts. However, if the patient states that they are going to engage in sexual activity, we want to counsel them about the ways that are safest to do so, particularly barrier methods such as a male or female condom. However, these are not 100% effective in preventing sexually transmitted infections. We want to identify infected individuals. How does this prevent sexually transmitted infections? Well, identifying them, diagnosing them, and treating them allows others and their partners to not get sexually transmitted diseases through contact with those who are infected. Also, we want to counsel and treat partners. So if a patient has a sexually transmitted infection, we want to encourage them to have their partners become involved in health care for treatment and counseling. Sometimes, depending on the sexually transmitted infection, a health department may become involved in this process and seek out potential partners to test them and get them involved in treatment. Vaccines for some sexually transmitted infections are also available. An example would be for HPV, human papillomavirus. This is Gardasil. These are given to at-risk populations. Trichomonas is the most commonly occurring curable sexually transmitted infection. Often, a woman may be asymptomatic. If she has signs and symptoms, she may complain of frothy discharge. Upon speculum exam, like the picture here, we may also see this frothy discharge. She could complain of a foul odor or itching. Upon exam, we may see strawberry spots or reddened areas on the cervix, as you can see in the picture. Treatment for trichomonas includes use of PO flagyl. Also, we'll educate the patient about avoiding intercourse until both partners are cured so that they're not reinfecting each other. Moving on to chlamydia, women are often asymptomatic. If she does have symptoms, they might include itching or burning, mucopurulent drainage, as you can see in the picture here, dull pelvic pain, bleeding between periods, and when we examine her, this picture is taken using a speculum visualizing the cervix. You can see that the cervix looks inflamed, and the cervix is often friable or bleeds easily. Infection of the cervix is most common, and this can cause pelvic inflammatory disease and sometimes can be the cause of infertility. How do we treat it? Azithromycin or doxycycline are currently used as forms of treatment. This is a curable sexually transmitted infection. Again, we would ask that partners abstain from sexual intercourse until both partners are cured. As far as pregnancy goes, we're concerned about newborn infection, particularly of the eyes. Also, women who have had chlamydia are at greater risk for tubal pregnancies. What kind of pregnancy is a tubal pregnancy? This is an ectopic pregnancy. Gonorrhea is another sexually transmitted disease that's often asymptomatic in women. Oftentimes, it's not until further complications arise, such as pelvic inflammatory disease, or PID, that a woman seeks treatment. If she does have symptoms, they might include purulent drainage, she might be complaining of urinary frequency or swelling of the perineal area, or even pelvic pain. Upon examination, we might see what appears to look like an eroded cervix. As you can see here in this photo, which is taken by use of the speculum, where the cervix is then visualized, you can see the drainage, and it does appear that there's some cervical erosion. Sometimes gonorrhea and chlamydia work hand in hand, so they will culture patients for both. Treatment includes ceftriaxone. Some providers may also treat for chlamydia at the same time, which would be the azithromycin treatment. And again, abstinence is encouraged until both partners are cured to prevent reinfection. What are the implications for the pregnant patient? Well, if she has gonorrhea upon delivery, our concern is about eye infection in the newborn. So what medication is it that we give to all babies after they're born? We give erythromycin eye ointment. If you recall, that ribbon of erythromycin is placed in the eyes from the inner canthus to the outer canthus to help prevent any eye infection related to this. Herpes is a recurring, lifelong viral infection. So this is not a bacterial infection that can be cured with antibiotics. This is a lifelong viral infection. There are two strands or types of HSV, which stands for herpes succinctovirus. They are HSV1 and HSV2. HSV2 is responsible for most cases of genital herpes. This can be spread through oral, anal, or vaginal intercourse. The first outbreak is generally the most severe. During outbreaks, we see vesicles forming, or blisters, and they're present in the vaginal or perineal area. Oftentimes when these blisters rupture, they can cause pain and inflammation, and the patient may report flu-like symptoms. Reoccurrences may occur. Oftentimes, if a woman has a reoccurrence, it can coincide with stress, her menstrual period, or times when she's immunocompromised. Well, we can't cure herpes. However, we can give antivirals to help decrease the incidence of reoccurrences. The treatment that we would give for this is acyclovir, and this is safe during pregnancy. So what is the concern for a woman who's pregnant, approaching delivery, who has herpes? The concern is that the baby will be infected with HSV, or herpes simplex. This can be a life-threatening situation. So you will see them use a clear speculum and look 360 degrees in the vaginal area to see if there are any lesions. Herpes, if there is an outbreak or if there's concern that there is viral load in the vaginal area, is an indication for a C-section delivery. Here are some photos of herpes. You see the one on the lower left is the genital area of a female who has herpes. You can see the vesicles there. And the one on the right is a neonate who has been exposed to herpes HSV2 infection. You can see the skin lesions on the baby. The first outbreak, as I said, is the most severe and also the most concerning for the pregnant mother. How does herpes come back? Where does it reside? It resides in the nerve ganglia of the affected area. So it can come out, as I said, during periods of stress, during a menstrual period, or times of immunocompromise. In the neonate, if the baby is exposed, oftentimes through vaginal delivery or through rupture of membranes where the fluid goes past the vesicles, gets viral load in it, and the baby is exposed, it can cause neonatal death, neurological problems, and blindness. So this is very serious, and as I said, typically if they do see lesions, this could be rationale for a C-section. Signs and symptoms for syphilis are commonly broken down into primary symptoms and secondary symptoms. Primary symptoms are almost flu-like. The patient might complain of a fever, weight loss, or malaise. This would take place and disappear in about 4 weeks. In about 6 weeks to 6 months, secondary symptoms then appear. These could include skin Condylomata lata. These are plaque-like warts almost. Arthritis, inflammation of the liver and spleen, and hoarseness in the throat or chronic sore throat. Also, patients may have a rash on the palms of the hands or the feet that is typical of syphilis lesions. Syphilis can cause blindness, it can have psychological implications, and death if it's not treated. Syphilis can be acquired through sexual contact, less commonly with contact through contact with exudate from the infected person, or transplacentally if the mother has syphilis and is pregnant. It's treated with benzathine, penicillin G. And what are the concerns for pregnancy? Syphilis can cause intrauterine growth restriction, preterm birth, and even stillbirth. Human papillomavirus, or HPV, is a lifelong viral infection. Often the woman is asymptomatic. It's not until she goes for an annual exam and they test her for HPV that she finds that she's infected. There are about 60 strands or genotypes related to HPV. Some of these are linked to the presence of genital warts. Some of them are also related to cervical dysplasia, or changes in the cellular structure of the cervical cells, up to and including cervical cancer. So there's been a lot of media attention related to HPV recently. Transmission is through sexual contact, genital contact. So not even using a barrier method such as a female or male condom can completely eliminate the risk of getting HPV because there's still some genital contact. Treatment may include podophyllin. However, this should not be given to pregnant women because it can be linked to congenital anomalies. Surgical removal, if she has warts, they can be removed, or cryotherapy, that may be done to remove the warts. You may have heard of vaccines for HPV. Gardasil is now in the regimen for young people. It's given to 9 to 26-year-old women, and there is also talk now in its approval for the use in boys, since men can also be affected with HPV and can transmit HPV to women. Gardasil is effective not against all strands of HPV, but strands 6, 11, 16, and 18. Cervarix is a newer vaccine that can be effective against other strands of HPV. So while the vaccines are great and can deeply diminish the occurrence of HPV and can help decrease incidence of cervical cancer because of that, they are not effective against all strands of HPV. The major concerns with HPV are its potential link to cervical cancer, and then some women, depending on the strand, may have genital warts associated with HPV. Acquired immunodeficiency syndrome, or AIDS, is a lethal, lifelong viral disease that is caused by HIV. There are some common methods of transmission. Most commonly, unprotected sex with an infected partner and needle sharing are to blame. As far as unprotected intercourse is concerned, this can be vaginal or rectal, anal intercourse. Sharing needles can be a problem with drug abusers who are sharing needles that have been used by an infected individual. Several other causes, not nearly as common, are transmission from infected mother to fetus, which we'll be discussing, and infection from blood products. Generally here in the United States, blood is tested really quite well, so we don't really see this as much as far as being a mode of transmission for HIV. Signs and symptoms of HIV or AIDS may include wasting syndrome, so tremendous weight loss associated with wasting syndrome. Candidiasis, do you remember what this is? This is a yeast infection, so commonly because their immune system is compromised, they may have yeast growing. In addition, it's not infrequent to see HSV, so we'll commonly see herpes virus in these patients. How do we know if a patient has AIDS? The initial test that's done is the ELISA test, enzyme-linked immunosorbent assay test. We'll also evaluate a patient who is HIV or AIDS positive for other sexually transmitted infections, since this is often linked to other risky behaviors or intercourse. Treatment, although it's not curable, we will treat with antiretroviral therapy. As far as pregnancy is concerned, there are many implications for the pregnant mother and newborn of this pregnancy. An elective C-section is often done prior to rupture of membranes. So the goal here is as little possible contact with infected blood from the mother. Also, we'll ask her to avoid breastfeeding since there are live blood cells within the breast milk. The newborn is often treated with oral antiviral treatment, and we will test the newborn even into childhood. Up to 18 months of age, the mother's HIV antibody can still be present, having the baby show a positive HIV test. So it's really not a good indicator early on. So we'll continue testing for HIV. If the baby is indeed positive, it has a very poor prognosis. The child may have immunosuppression, so we may see frequent infections, often failure to thrive, so it can't gain weight the way it should and grow the way it should, and often have neurological problems. Prevention of HIV/AIDS is focused on the transmission modes. So, we want to conduct sex education, tell people about condom use, and educate them about abstinence being the only way to 100% prevent HIV and AIDS. If they are drug users, we want to educate them about the use of clean needles. Certainly we don't want to condone drug abuse. However, for those patients, we do want to educate them about the importance of clean needle use. We conduct rigorous testing of blood products to help prevent HIV and AIDS being transmitted through the use of blood products. And we treat newborns of HIV-positive mothers. Perinatal infections are infections that occur during pregnancy that may affect the growing and developing fetus. When do you think this would be most harmful? This is most concerning if there is exposure to a perinatal infection during the first trimester. Infections later in pregnancy can still cause problems, including growth restriction, high drops, and neurological problems. But most concerning during the first trimester. Viral and parasitic agents of interest during this lecture will include Toxoplasmosis, Rubella, Cytomegalovirus or CMV, Group B Streptococcus, and Parvovirus B19. An acronym that includes many of the perinatal infections is TORCH, T-O-R-C-H. T stands for Toxoplasmosis, O stands for other infections including Group B Strep and Parvovirus B19, R stands for Rubella, C, Cytomegalovirus, and H, the Herpes simplex virus, which we've discussed. So this is a helpful acronym when thinking about perinatal infections. Toxoplasmosis is transmitted through the ingestion of undercooked meat or contact with infected cat litter. This can certainly affect the developing fetus, although it's normally not serious if an adult comes in contact with toxoplasmosis. But with the developing fetus, this can cause spontaneous abortion within the first trimester or neonatal death. It can cause convulsions and coma within the neonate, microcephaly, which would be a small head for its age, or hydrocephalus, the accumulation of fluid. It can also cause growth restriction. So what do we expect management to look like? We would expect this to be treated promptly or as soon as possible after we have identified a patient who's been in contact with toxoplasmosis. Treatment would be with spiramycin. If you're a visual learner, this picture can be helpful in seeing the link between potential cat litter exposure and also the consumption of raw meat and getting toxoplasmosis. Infection with rubella in the non-pregnant state is generally not terribly concerning or life-threatening. However, infection during pregnancy can cause terrible defects in fetal development. When do you think this is most concerning? Again, most concerning, at greatest risk for severe effects from exposure to rubella during the first trimester. Generally, the transmission is maternal-fetal, so the mother is exposed to rubella, has rubella, and it's transmitted to the fetus. Typically, these children may have cataracts, deafness, heart defects, mental retardation, or cerebral palsy. Treatment is generally geared to prevention. How do we prevent rubella? Generally with an MMR vaccine, a vaccine that contains measles, mumps, rubella protection. So we want to make sure that women are up to date on their vaccines. Cytomegalovirus, often referred to as CMV, is part of the Herpes Genitalis group. It's transmitted through the placenta or through exposure during delivery. Fetal and newborn complications of those who are exposed can include death, mental retardation, hearing problems, microcephaly or hydrocephaly, and hemolysis. Hemolysis can then lead to anemia and high bilirubin levels, or jaundice. Treatment, currently there are no treatments for cytomegalovirus, so treatment would be around problems and complications related to the exposure. About 10 to 30% of women have group beta strep as part of their vaginal, rectal, normal flora. The transmission of group beta strep can take place during delivery if a mother is not treated. Typically, women are tested at about 36 weeks gestation for group beta strep in the presence of it. If they are positive, penicillin or ampicillin is given during labor. However, if a woman comes in and she's about to deliver, we're not able to get the medications on board, we would treat the neonate after delivery. Maternal concerns for group beta strep include infection. She's at greater risk for chorioamnionitis or infection of the pregnancy. She's also at greater risk for endometritis and other infections. As far as the newborn is concerned, again, we're concerned about infection of the newborn. Group beta strep infection can cause stillbirth and exposure of the fetus and neonatal death. So it is important that the mother gets treatment. If we're not able to get treatment on board because of time in relation to delivery, then we would treat the newborn. Human parvovirus B19 is most commonly known for its cause of fifth disease in children. This is associated with a red rash on the body or a slap cheek rash. It's called that because the cheeks look red, like somebody slapped them. Maternal newborn concerns with parvovirus B19 during pregnancy include spontaneous abortion. Of course, this is associated with exposure to parvovirus B19 early on in pregnancy. Infection can be related to stillbirth or neonatal death following delivery. Some of this can be related to fetal anemia from the infection. The fetus is also at risk for hydrops or collection of buildup of fluid. This concludes the discussion related to infections as they pertain to pregnancy. If you have any questions, please get in touch with me.